Good afternoon, everyone. Today it's a pleasure to introduce Tina Zhou. She's one of the great C2 PGY5 presenting on artificial intelligence-driven ECG analysis. I guess we'll find out if it's a promise or a threat to cardiology jobs. Thanks for being here.
Thank you for having me. So I think very aptly I asked ChatGPT to come up with the title for me. So that's what I came up with, and I think it's appropriate. And I put the cake poster here. Disclaimer: I've actually never seen the show. I just know what it's about. But I think it's appropriate for two reasons. One is that artificial intelligence over the year is meant to sort of simulate and mimic how human intelligence works. So it's creating cake in the shape of human intelligence. And at the same time, I think it's now probably better at identifying the cake than we will be. So we'll see at the end of this presentation how everyone feels about that. A few more disclaimer: I am not an AI researcher. I know maybe the very basic concepts of artificial intelligence. So I will not go into the detailed methodology of how they actually derived all of these algorithms and how many NVIDIA chips they used. I am also not a researcher on creating risk scores, but I do find them fascinating, and we use them clinically frequently. So I think it's useful to talk about some of the numbers and stats. And then lastly, as you will see, a lot of this research is done at Mayo Clinic. So I'm not providing a plug for them. Neither am I trying to find a job there. It's just they do most of this research. So our objectives today are first to explore the core concepts of artificial intelligence and machine learning algorithms with a focus on how they are applied to ECG interpretation for predicting cardiac diseases. We will review a few real-world examples of how AI-guided ECG interpretation is used to identify hypertrophic cardiomyopathy, atrial fibrillation, and left ventricular dysfunction. I would say specifically asymptomatic cardiac diseases. We will also talk about how AI-driven ECG tools are currently being integrated into clinical practice or how they're proposed to be integrated. And lastly, we will address some of the limitations and challenges of using AI in medical diagnostic, especially concerns about data quality, algorithm transparency, and clinical adoption. So AI-enabled ECG algorithm can be used as screening tool. How does that work? So they take a normal ECG, go through the algorithm, and spit out a probability of someone having either atrial fibrillation, low ejection fraction, or any of these asymptomatic cardiac diseases. The way they do that, and why is AI algorithm in ECG a particularly good screening tool if it works? Well, a screening test should diagnose conditions that are underdiagnosed, have significant comorbidities or morbidities. They are potentially treatable, and they do not currently have effective routine screening. And I think we can argue that a lot of asymptomatic cardiac diseases like atrial fibrillation or LV dysfunction currently do not have effective screening tools and can have significant long-term effect. And what makes ECG or AI-guided ECG interpretation a good screening test potentially? It's very scalable. It's a very easy to do test. It's very relatively low cost compared to other diagnostic. It can be quite sensitive and accurate. But we'll see about that with the various research that I'm about to discuss. So how does AI actually learn to read ECGs? Well, how do cardiologists learn to read ECG? So we look at the ECG, we look at different segments, we look at maybe at most a small box, which is a lot, it's about 40 milliseconds. So our human eyes only sees about 2.5 hertz, even if with good glasses, and then no one's poring over with a magnifying glasses looking at ECG generally. It's usually looking at a small box, looking at the morphology, and sometimes just a hunch. Now, the way AI does it, or rather the visual, the visual aspect of AI, there are different methods, but the one I'm going to discuss is how they just look at a picture. is that they can break down the information into a lot finer data points. So they see an ECG at up to 500 hertz, some potentially even more going into the future. So that gave us 500 per lead, 10 seconds per lead, and 12 leads. So that's 60,000 data points. So they can see way more of the minutia of ECG than we can. So that's the first aspect. Then they take all this data from the ECGs and put into a deep neural network approach. So you probably will hear about convolutional neural network the most often. It came from neuroscience, when the idea is that you have all these neurons in different layers, and they're connected to each other to break down complex information to into different ways of interpreting and different ways that information correlates with each other, and over time, with strengthening, some pathway becomes stronger than others. So the deep neural network is supposed to simulate that. So a very crude example will be, let's say, layer one will be they look at the ECG and they say, this is a P wave, this is a QRS, this is a T wave. And layer two, maybe they look a bit more finely and say, well, this is the upstroke, this is a downstroke, this is the angle of the repolarization, of the depolarization, and they go layers and layers and layers. And then in the end, they find ways to connect the layer to match the output to the input. So with each iteration, they are strengthening some of the connections, they're weakening some of the connections. And when they're done training, so to speak, it's supposed to represent the data set that was fed to it, and supposed to be able to predict using this algorithm. Now, also a very brief introduction to risk scores. We use them quite often, but how they're derived and what the numbers mean, I want to chat briefly about that. So the most common quantitative description of risk score is the area under the receiver operating characteristic curve. So it's supposed to be a score to discriminate between those with high risk or low risk of having a certain outcome, in this case, disease. So for the purpose of, just to simplify it, if the line goes straight across, it cannot discriminate between low versus high risk. So it's generally a riskless score, useless score. If it's yellow, which is really close to one, it means it's excellent discrimination between discriminating between those with high and low risk. And then the purple line in the middle is somewhere it's okay. So it's a good score, but not excellent score. Generally, these risk scores are derived using fairly complicated regression models with a lot of variables, usually clinical variables, laboratory variables, and they come up with some sort of weighting system for all of these variables to come up with a risk score. So it's sort of traditional regression analysis. AI is changing this by using big data and then by using the convolutional neural network to come up with the risk score. So delving into the different cardiac diseases. So first of all, how can AI-guided ECG analysis predict asymptomatic left ventricular dysfunction? So this is a paper published by the Mayo Group. When they looked at the background story was Dr. Noseworthy took over as the EP staff at Mayo Clinic, and he had access to close to millions of ECGs at high quality, and he thought, okay, you know what, I should do something about this. And so what they did is they took their population of 600,000 patients, which is a lot, even PHI trials were looking at thousands, and we're looking at hundreds of thousands of patients. Of note, of this population, unselective population, about 8% has an ejection fraction less than 35%. So these are people who have ECG as well as echo data to confirm the ejection fraction. One could argue 8 is a little bit high in the general population. When I did a very prelim search, the general population, you're only looking at about 2%. So this population is higher, has a higher rate of asymptomatic or symptomatic LV dysfunction compared to the general population. But hey, people get referred to Mayo for a reason, I suppose. So, and then what they did then is they divide this 600,000 patients into and then into the various data sets. So they have the training data set on the bottom, which are about 35,000. They have 8,000 to validate the network, and then about 50,000 to use to test their algorithm. And of note, in the testing data set, which is the 50,000 here, about 8% of them have less than 35% ejection fraction. So the testing data set and the training data set are fairly similar. Now, so this is what they found in terms of the risk score performance. As you can see on the left here is the receiver operating curve, and both the validation set and the testing set performed really well. You're looking at an AUC of 0.93, which is very close to 1. And if you actually break down also the sensitivity and the specificity, overall the test did really well. So we're looking at almost 90% sensitivity, 83% specificity, and it's a negative predictive value of almost 100%. So it's good at rolling out as a test. What's also interesting is the algorithm predicted a bunch of patients to have decreased LVEF, but they don't actually have it on the echo that was paired with that ECG. And when they follow these patients over time, they found that these quote unquote false positive actually developed significant LV dysfunction in the future. So the AI algorithm is seeing in the ECG something that we can't even see on echo yet. And they found that the hazard ratio of these quote unquote false positive is 4.1. These patients are 4.1 more likely to develop LV dysfunction in the future if they're initially categorized as low EF falsely. It turns out it's not false, it's probably just premature. And maybe is some value to serially screening these patients. Now, how can this be incorporated clinically? So the Mayo group actually conducted a prospective study using AI-guided ECG algorithm to predict LVEF. So what they did is they took patients who are referred for an echo. So you can argue these are already somewhat selected patients, so they're not completely unselective. And they either undergo echo or they would undergo an ECG-enabled stethoscope, which I'll show you. Basically, it's taking ECG data from the patient and they use their algorithm that they developed to predict their probability of having decreased LVEF, and then they compare to the gold standard, which is the echo result. So it's about 100 patients, and they put the stethoscope on the chest for about 15 seconds, so close to how long a regular ECG would be. And it's fairly easy to do because you were listening to the patient while recording the ECG at the same time. Now, in this group, you have about 7 patients with EF less than 35%, which again, is quite similar to their training data set of about 8% decreased LVEF. So at least they're consistent between the two studies. And this is what it looks like. So you have a stethoscope connected to your phone, and you just place this device across the chest. And they also tested a few different positions of this ECG-enabled stethoscope to see which one performs the best. And the idea is handheld, it's easily accessible, it's probably chargeable, and you don't have to worry about bringing the echo tag, and bringing the ECG tag and quality of the ECG, etc. Now, so what did they find? The AUC of predicting low EF of less than 35% is 0.91, which is excellent and quite similar to the original retrospective training data derivation. And again, great sensitivity, specificity, great negative predictive negative predictive value, as well as positive predictive value. And for the predicting LVEF less than 40%, the model still did quite well. And for predicting less than 50%, the AUC progressively decreases, but 0.84 is still a very excellent C-stat. So the AI-guided ECG algorithm can predict asymptomatic LV dysfunction. So now switching gear to AI-guided ECG analysis of asymptomatic atrial fibrillation. So again, Mayo Group, they took a very similar population of patients compared to the last, and this time they included 180,000 patients, dividing them into 70% training data set, 10% internal validation, and 20% testing. And again, very similar prevalence of atrial fibrillation. So about 8% in the testing data set. And the way they handle the data here is a bit different. So they have patients with no atrial fibrillation on top, who each ECG is supposed to be normal sinus rhythm. So they included all of that for the training data set. But for those with atrial fibrillation, they included the ECGs from the 31 days before what they call the index ECG, which is the first ECG that showed atrial fibrillation. And the idea is that some of the ECG signature of atrial fibrillation may be present before the actual diagnosis of AFib on ECG, but they didn't include all of the previous ECGs. So for example, this could have been, say, 10 years ago, maybe by then this ECG signature is not there yet. So I think it's a quite fair choice. And then they also did two analyses when they did the testing and validation. One is they just used the first normal sinus rhythm ECG within the window of interest. So for main analysis, it will be this ECG because it was the very first normal sinus rhythm in that 31-day period. The secondary analysis is they picked the ECG with the highest score for predicting atrial fibrillation. And the idea is that potentially this could be more sensitive, but that requires the algorithm to be applied to every single ECG in this 31-day window. So the result, again, you will see a theme is that the AUC and the ROC curve looks beautiful. So you have a main analysis AUC of 0.87, a little bit lower than the LVEF study, but still excellent. And the secondary analysis, when they use the ECG with the highest score, and surprisingly, the AUC is a bit higher, which is at 0.9. And sensitivity, specificity are good, not as quite excellent as LVEF study, but about 80% and above, which is quite excellent already. Now, in terms of predicting atrial fibrillation risk, there are clinical risk scores currently developed already. So how do they compare? So here they compare the AI-guided atrial fibrillation with the Charge AF score, which is supposedly fairly applied score for predicting AFib. And as I mentioned earlier, these risk scores tend to take clinical characteristics. So we're talking about age, race, weight, blood pressure, et cetera, things that make clinical sense. And they came up with a risk score for that. And then on the right is the AI algorithm, which I just discussed. And this table down here showed you the results of the CSTAT. Now, the Charge AF CSTAT has a AUC about 0.69, while the AI-guided ECG CSTAT is about 0.69 as well. So they're quite similar. And of note, the 0.69 here for the AI ECG is lower than what the training data set was able to produce. I'm not sure why. I think it's probably something to do with the population they test in, and it's something to keep in mind that the original derivation paper always gives you probably the best AUC you'll ever see. How they are in real world or clinical setting is probably a bit discounted. Either way, at least it performs as well as Charge AF risk score, and the author's argument is that the AI-guided ECG probability is a lot faster to derive and does not require all the clinical information, which is a fair point. Now, how does it affect care in the world of atrial fibrillation? So similarly, a prospective study at Mayo Clinic where they looked at screening for atrial fibrillation during sinus rhythm. Now, the inclusion criteria is interesting here, and I think it's appropriate, is they chose patients in whom a diagnosis of atrial fibrillation would actually change management. So these are people who have CHAT score of, I think they picked at least 2 if they were to have atrial fibrillation, and they would meet criteria for stroke prevention with anticoagulation. So what they did is they picked 1,000 patients who are eligible and consented to do the study. They applied the AI algorithm to their ECG, after which they gave them a 30-day continuous cardiac monitor. And so it's a real-time monitor. So as soon as they develop atrial fibrillation, the investigators will know, and they will continue to monitor for additional 72 hours to look at the AFib burden, in addition to just the diagnosis of atrial fibrillation. They then also picked controls that are propensity score match. So it's not a randomized control trial, but they're supposed to be patients who are similar in terms of their stroke risk and similar in terms of age, sex, and other clinical factors. The primary outcome here is a yes or no, did they get diagnosed with atrial fibrillation during the 30 days after the initial ECG prediction. And they also looked at atrial fibrillation burden, so those with greater than 6 minutes, 24 hours, and percentage. So the primary outcome of the 1,000 patients that they enrolled in the trial, 54 of them ended up being diagnosed with atrial fibrillation. So that's about 2%. And this is a busy table, but I'll walk you through. The first row here are the people with a diagnosis of greater than 30 seconds of atrial fibrillation. And of the 1,000, 300 patients were marked as low risk, and by the algorithm, but of these 300 low risk patients, 6 of them, or about 2%, actually have atrial fibrillation. And then of the high risk, you're looking at about 8%. And this percentage decreases as we go through the different duration of atrial fibrillation. And they didn't provide us in the paper, but sort of the back of the hand and official calculation, the sensitivity for diagnosing atrial fibrillation greater than 30 seconds is about 89%, a specificity of 99%. Positive predictive value, not the greatest, almost 8, but negative predictive value is excellent. So it's a really good rule-out test for what it's worth. Now, they also compare the outcome of AI-guided care versus usual care. Usual care in this case is the propensity match group, where they don't go through any screening. They have symptoms, they go to a physician, they get a Holter, and it demonstrates ECG, so to speak. And they find that the cumulative risk of diagnosing atrial fibrillation in the high-risk intervention group is higher over time, which isn't entirely surprising because they are being flagged as having higher risk atrial fibrillation early on, and they actually go through screening. So I guess the idea of this graph is showing that if you apply this algorithm, you are more likely to identify more atrial fibrillation over time. Now, switching gear to predicting hypertrophic cardiomyopathy, I will spend a bit more time on this topic because the research in this area seems a bit more robust and a lot more nuanced. Again, Mayo Clinic paper, and this time they include about 3,000 hypertrophic cardiomyopathy cases, and with a control about 60,000. The ratio works out. I think it's still higher probably than the prevalence of HCM in the general population, but it certainly provides enough data for the training and validation of their algorithm. So similar model development breakdown, 70% in training, 10% in validation, 20% in testing. This is like a fairly standard breakdown across all of their paper. In this case, for the sensitivity, they did both the sensitivity analysis and the subgroup analysis. And for the sensitivity, they actually changed the they played with the prevalence of HCM in order to see whether this algorithm, how effective this algorithm is. They also look at the subgroups of the algorithm, of the population. And the reason being is that, if people with LVH, people with HCM usually just have LVH on their ECG. So how well is this model performing at identifying specifically HCM, or is it just identifying patients with LVH on their ECG? So again, a very beautiful curve on the left. As you can see, the training data set, the AUC is almost 1. The validation and testing data set are also very close, all well above 0.9. And on the right, not all of the paper demonstrate this, but here it actually shows you how they pick the probability threshold. So the first column here is the probability of having HCM based on the algorithms. So 5%, 11%, 25%. And then each threshold probability of choosing whether someone is considered a positive case versus negative case, they give you the sensitivity and specificity and the other stats as well. So based on this table, they picked a probability threshold about 11%. In other words, if the AI algorithm look at your ECG and says you have an probability of having HCM above 11, you're considered a case by the algorithm. They also did the subgroup analysis. So they picked at a threshold of 11%, they looked at different characteristics, different subgroup of the population in which this algorithm may be most useful. So to interpret these bars, the idea is that the higher the OR ratio here, the more useful, so to speak, the algorithm is in the subgroup. So they identified that age less than 40, in this population, this test is probably the most useful with the highest OR ratio. The other piece they looked at is they divided the patients into those with normal ECG and those with LVH. And I think this is an important and helpful cases because there are a lot of patients with HCM who just have normal ECGs, and we do tend to miss those cases unless there are other clinical suspicions for HCM. So among the normal ECGs, the C-stat is again quite excellent at 0.95, and it's a very sensitive and fairly specific test with a very good negative predictive value of almost 100%. And among the ECGs with LVH, they were still very good at predicting HCM. So it's telling us the algorithm is looking beyond just LVH on the ECG to identify patients with HCM. Now, other aspects of HCM care, one is the other thing they looked at is how good is that the algorithm not just predicting HCM, but predicting whether a patient with HCM would be genotype positive. Why is that important? So as you know, HCM has a lot of different mutations, and different mutations have different prognostic and diagnostic value in patients with HCM. And genetic testing can also be quite difficult to interpret because of various variants of certain significance and different penetrance and different inheritance pattern, etc. So having a test that can maybe add to our genetic testing results for interpreting whether someone is gene positive could be helpful. Access to genetic testing is often limited. Quite frankly, only really in academia will we be able to access genetic testing fairly easily and fairly quickly. And we currently do have risk scores for predicting genotype positivity. One is developed by the Toronto group, one by the Mayo group. But again, how well these performed in clinical setting is a bit disappointing. So the idea is, can the AI algorithm supplement or potentially replace the existing genotype score? So I won't go into too much detail, but here on the left is comparing the Toronto score to various AI algorithms using slightly different statistical methodology. And the red is the Toronto score, and the other three are the AI algorithm, so it performs better. Same thing here with the Mayo score. The red is the Mayo score, and the other three are all AI algorithm. And what I want to show is this table where it actually broke down how how well the algorithm performs in different categories of risk. So each row is the probability of genotype positivity based on the algorithm. And highlighted in red here is one of the three AI algorithm. And you can see that the AI predicted about 38% of the patients who are at low risk of having genotype positivity, and sure enough, only one of these 38 actually have one. While compared to the high risk group, AI algorithm predicted 16 of them would have gene positivity, and 14 of the 16 actually do. And when you compare that to the Toronto score and the Mayo score, you can one is these two clinical risk scores are under predicting patients who are at high risk or of having genotype positivity, even though when they did predict it, the rate is high, they're missing a lot in their low and intermediate group. So that's interesting, because it means that the AI ECG are looking at aspects of the ECG that may be associated with genotypes that we just cannot see with naked eye. The other piece that's helpful using AI-guided ECG is predicting high-risk imaging features. So patients with a hypertrophic cardiomyopathy are at different risk of having sudden death. And we all know that there are various factors that often require cardiac MRI to identify. So things like percentage of late gadolinium enhancement and the actual wall thickness. Sometimes the echo may not correctly call it, or sometimes echo will miss small apical aneurysm that will only get picked up by MRI. But MRI can be difficult to access, expensive, and takes time. So the idea is, can ECG identify features on the AI-guided algorithm? Can they identify features on the ECG that can predict these imaging finding that only MRI can pick up? So what they did, similar to the ECG, go through an algorithm here, and they came up with 4 features for the AI algorithm to predict. So that's the rate of systolic dysfunction, rate of massive hypertrophy, LV apical aneurysm, and extensive late gadolinium enhancement. And on the left here is they used the output. So the bottom is their holdout testing, so training and testing group, and then they have an external validation group coming from a completely different country and presumably very highly different ethnic composition. And they looked at the C-stats for each type of high-risk imaging feature, and as you can see, it's quite good at predicting systolic dysfunction, discriminating those with systolic dysfunction, massive hypertrophy, and the highest is the LV apical aneurysm, and also does relatively well for extensive LGE. What they also did was, well, now that we know the ECG can be helpful for predicting these features that sometimes only MRI can see, can we change our pipeline? So instead of everyone getting an CMR after they get an echo, you do an echo ECG, and based on the results of the algorithm, only selected patients get cardiac MRI. So potentially that can reduce the amount of expensive testing and reduce the amount of wait time. So of the 1,600 patients, the AI algorithm recommended about 40% of them to have cardiac MRI. And among the 600 MRI that was done based on the AI recommendation plus echocardiogram, they identified 162 of the 167 patients who have high-risk features. So in other words, about 5 patients or 3% of those with high-risk features were missed by the AI plus echo algorithm. And of these 162 patients, the AI was able to identify 200 of the high-risk features. So each patient can have more than one high-risk feature. So again, very, very good. It can predict systolic dysfunction in 100% of the patients, massive hypertrophy in 100%, and apical aneurysm in almost 100%, and an extensive LGE. So I highlight the extensive LGE here because the other three features, so systolic dysfunction, massive hypertrophy, and apical aneurysm, can usually be seen on echo to some extent. So what is the ECG really going to add in addition to it? And I think this is what LGE plays in, because that's not something we can usually see on echo. So the fact that the ECG can identify this feature that usually only MRI can see, it's quite interesting and telling. And as you can see, it has great sensitivity, specificity is okay. But the testing efficiency is great. So it's good at picking out the ones who actually need a CMR. Now, I've gone through a whirlwind, very shortened overview of cardiac diseases that can be diagnosed by AI-guided algorithms. But are these tests really worth it? It's a bigger question. Can we actually apply them clinically? And is it effective? Is it cost effective? So how does it perform compared to other clinical screening tests? So when you compare the AUC to other medical screening tests, so B-type natriuretic peptide for heart failure, pap smear for cervical cancer, and CHA2 score for estimating a risk stroke, you can see that the CSATs are actually not that great. Now, these numbers are generally derived from real world samples, not necessarily the original risk score prediction. And as I said, often these risk scores, when applied in real world, we need to discount them a bit. So the AUC of 0.96 in the Mayo database may not be nearly as high when you actually apply it to real world data. And then we just don't have enough studies quite yet to show exactly how good they are at risk scores. But just preliminarily, the pap smear is only a 0.7. So far, it seems promising, but I think it needs to be cautious in saying that these risk scores are very good at predicting risk. The other piece is, are they cost effective? The idea is that the ECG test is cheap to do. The AI algorithm applied takes a lot of resources to train them, but once they are actually developed, the application of it shouldn't be that hard. So you would think that the AI-guided ECG algorithm would be a relatively cost-effective strategy. So someone actually studied this. I think this is also the Mayo Clinic, where they looked at the AI-guided algorithm to detect asymptomatic LV dysfunction. They used a decision analysis model, so they didn't actually take real-world data and compare those who got algorithm versus those who didn't get algorithm. How long did they live? What their quality of life is, what their actual cost is. So this is what they call decision tree analysis, where they base it's all a lot of parameter estimation. So estimating what is the quality of life when they have asymptomatic LV dysfunction, what is the cost to the healthcare system when an AI algorithm identifies someone as having asymptomatic LV dysfunction. And that cost isn't just the ECG itself, neither is it just the echo itself, but also all the physician office and visits. They also included potential ischemic testing. So, perfusion scans, angiogram. They included potential hospitalization costs associated with diagnosis of heart failure, which I think is interesting because the idea is that you're diagnosing asymptomatic LV dysfunction. So I don't actually know how much the hospitalization would play a role. Well, the one thing they did not account for is how much the treatment, early treatment of asymptomatic LV dysfunction can affect their quality of life. So I think that would just be even more complicated. In the long story short, it's a very complicated parameter-driven model. for predicting both the cost and the effect. And they looked at the screening in those at age 85 or above for their first analysis, and they compared the cost of no screening, which is about $280,000 US dollars estimated, and that's just how much they think a 65-year-old will cost the healthcare system with their usual profile comorbidities. And they looked at screening with AI, and then they compared the effect here, which is the difference in quality of life, just adjusted life year, and what they derive as an ICER, which is the incremental cost effect ratio. So how much does it cost the healthcare system to produce one extra quality of adjusted life year, not just being alive for additional year? And the number they came up with is about 45,000 USD. Now they then lowered the age to 55-year-old and then they noticed the ICER went up to about 48,000, and when they screened 75-year-old and above, and went up even higher to about 52,000. So overall, you're looking at the 40 to 50,000 range. I was trying to find something in the literature where I can compare to this study. So I was looking at, ECG screening for detecting AFib, or looking at pap smear and colonoscopy and the other well-established tests. It's hard to find a paper that's truly comparative. But I can say that for a lot of these cancer screening, the ICER is usually somewhere in the thousands. So it is expensive, but it doesn't necessarily break the bank compared to some other screening tests. Now, what are some challenges with artificial intelligence? Perhaps the biggest one is the idea that AI is a black box. So we feed this algorithm all this data, is spit out an output, and we have no idea how AI actually reached this conclusion. And some of the more anecdotal stories of early days of AI research, when they just did what they call unsupervised training, where there's not a lot of supervision from the software developer to tell the algorithm or to guide the algorithm in some ways to reach their output. Some of the stories are quite hilarious how the AI actually reached their conclusions. So for example, early days of research when they teach AI to identify objects. An example was they asked the AI to identify a dumbbell, and it was very good at it. And later on, when they actually try to break down the algorithm, is what they realized they are not actually looking at the dumbbell in the picture. They just found that every picture with the dumbbell in it also has an arm holding the dumbbell. So what they're actually seeing are the arms in the pictures. Similarly, in the medical field, early days of computer vision training, when they looked at melanoma versus other skin lesions, AI was very good at identifying melanoma using sort of the more rudimentary unsupervised model. And when they actually looked at the model and see what is AI seeing, it's not actually the melanoma they're identifying as melanoma. It is the ruler that's right next to the melanoma that they're identifying as a feature for the disease, because most pathology pictures with melanoma will have a ruler next to it showing how big it is. So that can pose a danger because we don't actually know what it's doing. The second piece is that what we're really hoping from AI isn't really just giving us an output, but also perhaps teach us something. Like I said, it can see as a resolution that we cannot see at. So it will be helpful for us to learn from it what exactly is it seeing associated with disease, and potentially help us understand the pathophysiology of disease better. Now, over the past few years, this idea of black box slowly breaking down, and more so in the non-medical fields, I think researchers are more and more conscious of trying to create explainable AI algorithm. In the medical field, there are some research projects that looked into it. So one example is, again, the Mayo group. They looked at how their algorithm diagnosed hypertrophic cardiomyopathy. What are they looking at in the ECG? And here on the right are what they call heat maps. So they basically, again, trained the algorithm on a bunch of ECGs, and then retrospectively look at the algorithm and say, what aspect of this ECG is giving AI the clue that this patient may have HCM? And what I think what's shown here is very interesting on the right is that each box is a case of the testing database where the patient has various ECG feature. So for example, the top left is a 37-year-old male with ECG feature of LVH. So what the AI is seeing in the ECG is this the darker or closer to red is the more important this aspect is. They're seeing this area of the ST that they identify as associated with HCM in addition to just LVH. And similarly, they're able to identify it for those with atrial pacing, with dual chamber pacing, with left bundle branch block, those with atrial fibrillation. I think this part is particularly reassuring that the heat map also picked up the fact that this ECG does not have P wave, so it correlates clinically, and what it teaches us more than just it's more than just the fact there's T-wave inversion, or more than just the fact that there's significant LVH by QRS criteria, but how the ST looks and the various patterns that may be not available to naked eyes are actually what's driving the decision. Now, so after that, my conclusions, one is AI-guided ECG algorithms can be used as potential screening tests to detect asymptomatic cardiac diseases. I think I've demonstrated that quite well with the few examples. However, it remains unclear how well they actually performs. The Mayo Clinic data is clean, and patients get referred to Mayo for a reason. And most of the patients there are probably of certain ethnicities that may not be applicable to the rest of the world. There is some research showing whether the algorithm would hold up with different types of patient population, which I did not demonstrate here, but I would say that this area of research is still in its infancy. And it's not clear also who should get screened based on these algorithms. One of the trial for the atrial fibrillation, they included those at higher risk of stroke, which makes sense. But what about LV dysfunction? Who should get screened for asymptomatic LV dysfunction and at what age? And the last piece is, how do we address the black box of AI and actually make sure that what it's seeing makes sense and what it's seeing can teach us something? So this is an area of active research, and I think area for a lot of opportunities. And lastly, which I didn't put on the slide, that Dr. Noseworthy talked about at one of the conferences I was at, is they actually had an Epic plugin. So EmergeDoc, who can look at the ECG, can click a button on the Epic interface, and it will spit out a probability that this patient with this ECG will have this probability of having LV dysfunction or atrial fibrillation, etc. So now that we're on Epic, I think this is something that we could potentially do if we're interested in research in this area. So after that, I will stop and answer any questions. Thank you for your attention. Hope that was interesting for you all.
Okay, Tina, thank you so much for the great round. I never thought the ECG reading is as complicated. Luckily, I only look at ST segments. So, we'll open this the floor for questions. So actually, just want
Tina, maybe.
Yeah, Sean, go ahead. No, please do.
Sorry, Tina, great job. Very complex area, very exciting. I'm definitely not an expert on calibration and discrimination and statistics, but I did recall that, for example, the very impressive noseworthy, the Mayo Clinic analysis that was published in the Lancet that you talked about as an example of the potential for AI to sort of predict the C statistic, the sort of calibration was fairly modest, right? I mean, in the 0.6, 0.7 range. Now, that's not to be critical because, the gray score that we developed for clinical predictors, clinical factors in a post-acute coronary syndrome patient population to try to predict what their outcome might be in the next, year's time is, not a whole lot better than that. The CHADS VAS scores that we used for predicting, again, the likelihood that somebody with atrial fibrillation might have a systemic embolism, embolic ischemic stroke, again, are not, the calibration is not a whole lot better. But it is a reminder that even with AI, those C statistics, those calibration, that ability is modest at best. And so I'd just be interested in your thoughts on AI as a potential great tool, but whether, does this offer up that much more than sort of conventional statistical analysis and developing a score, which of course is much less black box, as you pointed out, than at least for most of us from AI. So are we that much further ahead at this stage in time compared to a traditional multivariable logistic regression or other statistical tool methods to land on something that's sort of clinically applicable?
Mm-hmm. No, it's yes, the papers didn't really talk too much about calibration, and there are some papers where they looked at the AI risk score as an addition to something that's clinical, so in addition to the Charge AF
Right.
score, as an addition to the Toronto or the Mayo score. And I do recall that I think in some cases it may be a marginally better. Some cases actually there was
Right.
no difference. And I think where it becomes helpful is where we didn't have risk score. So, for example, the asymptomatic dysfunction, we currently don't have risk score for these patients. So, short answer is I don't know, and I think that we may need a little bit of modeling to see how effective it can be and how cost effective it can be, as someone mentioned, the overall in the healthcare system. And the second is I think we need real world data to actually see.
Yeah, but very exciting, and thank you for sharing that.
Excellent. Any other questions? I mean, Tina, I just have, so you mentioned EPIC as a one way of looking at it, but let's say, in a family practice where this can be utilized, I mean, I don't have experience with AI, but I understand there's a lot of AI softwares and developers, not necessarily ChatGPT. So how do you foresee this? Is it like a picture of an ECG you upload to an app, and are all the AI, obviously created equally, or is it going to be, a source of confusion of, like, if you get an AI result, is it from this provider or this, or is from this software or the other? How do you foresee this in, let's say, family practice? Because that's where a lot of screening for cardiac conditions may take place.
Yeah, I think before we implement it widely, there definitely is a same point as made prior. We definitely need to actually see some real world data. In terms of the software, right now it's not proprietary. It's in the public domain. It's not easily accessible. I don't know if family practice is the right place to implement it, is what I would say. And if the AI research does continue to evolve, and on the flip side, it may become a screening guideline. So, for example, all patient above a certain age with smoking history should get an ultrasound for diagnosing AAA. And would AI algorithm be similar in weight and in effectiveness as those type of screening tests? I don't quite think so, because it's still an intermediary. It's not like ultrasound actually give you a diagnosis of AAA. Well, ECG will only give you a probability. I don't, so I guess the conclusion one, I don't think family medicine will be adopting it anytime soon. And two, the algorithm will probably stay public. I don't think this is going to be proprietary algorithm. And ultimately, it will be like the various type of risk scores that we have for diagnosing heart failure outcomes. There's a Seattle, there's a bunch of others. It will be up to the clinician to decide which to use. But I think for now, and the idea of the AI algorithm is that if someone else were to develop an algorithm, it shouldn't be that far off. Is the idea. So even if there are multiple algorithms, I don't think it will make a huge difference.
It's interesting in the CCS guidelines. It's interesting that there's an element. Oh, sorry. There's a recommendation on opportunistic screening for AFib, for example. Not necessarily ECG based, but clinical examination, or so it will be interesting to see when this is more mature, how would that apply? Okay. I'm mindful of the time. Any time for any last question? And I have to ask if this was applied in STEMI. I cannot not ask. So is there any research in that area?
I don't think so. Okay, and no. And I think the idea is for it to be a screening test, not a diagnostic test, right? The ECG STEMI is more of a diagnostic test. And I don't, if there's a clinical suspicion is strong enough, I don't really care what AI tells me on the ECG, the patient's getting a cath.
Okay. That's an important message. Okay, excellent. Well, Tina, thank you so much for the great round, and thanks everyone for being here. And just a reminder to fill the evaluation for these rounds. And again, thanks everyone.
Thank you all.
Well done. Thanks so much, Tina.
Great job, Tina.
Thanks.